Good afternoon or good evening, wherever you're tuning in from today. We're really thrilled to be having you on our part four of our continuing education webinar series titled Wound Care Strategies for Keeping the Patient at Home and in the Community. And we're graciously thankful of Perfuse MedTech for helping put on this entire webinar series. And thank you to everyone who has been tuning in with us over the past few webinars. But if this is your first webinar that you've been tuning into as a part of this larger six-part series, welcome. You can always go and check out the recording of the past presentations on our website at www.nswoc.ca. But for now, we're going to be talking about today's presentation, which is pathophysiology and treatment of venous leg ulcers and ulcers due to PAD. And we have a fantastic presenter with us today. And before I introduce Dr. Stacey, I'll just go over a couple little housekeeping items. First things first, as I just mentioned, we will be recording today, so you can definitely watch this back if you have to leave early, or if you want to share this with your colleagues, please feel free to do so later on. We're also going to be giving a certificate of attendance to all those who are in attendance today. So don't worry about that. It usually takes us about 1 or 2 business days to get that over to you. So stay tuned for an email in your inbox with your certificate. We're also going to be doing a Q&A session at the very end of this presentation today. Thank you to those who did submit some questions in advance, but we will be getting all those questions answered at the very end. If you have any questions throughout the duration of the presentation, just click on that Q&A button in your Zoom toolbar, and I'll be happy to organize those and get them answered at the end. I see that everyone's already done the prompt I usually get to at the beginning, which is to type in the webinar chat button there and let us know where you're tuning in from, whether it's in across Canada here. We know we get some international attendees as well. So type in where you're tuning in from or maybe where you're working. We'll be happy to keep the conversation going there. But without further ado, I'm very excited to be introducing our guest speaker today. Some of you might have already heard Dr. Stacey speak earlier, but Dr. Stacey is a vascular surgeon, came to Canada in 2014 as the surgeon-in-chief at Hamilton Health Sciences and professor in the Department of Surgery at McMaster University. Dr. Stacey completed his medical degree at the University of Western Australia and is a fellow of the Royal Australasian College of Surgeons. He spent 2 years working at St. Thomas's Hospital in London, UK, where he conducted his research for his Doctor of Surgery degree. Dr. Stacey also took on the role as Chief Medical Executive and Executive Vice President Academic at Hamilton Health Sciences in 2018 until mid-2023. And Dr. Stacey also established active research programs in wound healing in both Australia and here in Canada. Those programs include, or have spanned basic science, translational research, and clinical research. He's currently working to commercialize a point-of-care test of healing status in chronic wounds. He was the first president of the Australasian Wound Management Association, which is now Wounds Australia, and is the founding chair of the World Union of Wound Healing Societies. He has a passion for advancing the wound care for patients and has previously established a multidisciplinary diabetic foot ulcer clinic and a venous leg ulcer clinic in Australia, and now looking to do the same thing in Canada too. But for today, you're going to be talking to us about the treatment and pathophysiology of venous leg ulcers and ulcers due to PAD. So I'll pass over the mic and the slides to you, Dr. Stacey. Thanks so much.
Great, thanks very much that introduction, Troy, and welcome everybody. So yes, as Troy's indicated, I'll be talking on this topic tonight, which is a little bit of a follow-on from the topic that I spoke about in one of the previous webinars. But before we get underway, these are my conflicts of interest. I do have some active engagement with a number of different companies. Also, I'm involved in Woundpedia as a board member, and I've had previous consultancies with different companies in wound care areas in the past. So today we're going to be just touching a little bit on the pathophysiology of venous leg ulcers, similarly with ulcers due to peripheral arterial disease. So what is the mechanism behind which these develop and they have this impaired healing, and then go on to touch on the strategies for how to deal with these and how to treat them. And we'll focus a little bit on things that you can do, in terms of early things you can do that will help to keep patients in their own home. So just to sort of recap on the last talk that I gave, there is a commonality in many different types of lower leg ulcers, whether it be arterial, diabetic, or venous ulcers, in terms of the final problem that they have. They get to it by different etiologies, but all of these have a problem with the microcirculation in the skin. And That comes in arterial disease, fairly self-explanatory. There is a problem directly in the arteries, so limited blood flow getting to those skin vessels. In diabetic foot ulcers, it can be a combination of things. There is some change in the microcirculation with diabetes, but there can also be change in the larger vessels. But in addition, in diabetes, because of their neuropathy, there is more compression on the vessels when they're standing or walking, and they're not relieving that pressure sufficiently to enable increased circulation. With venous leg ulcers, it comes from a different mechanism. So there is a problem with ambulatory venous hypertension or venous pressure, which I'll explain in a little bit. And this leads to problems in the microcirculation and ultimately problems with wound healing. And as part of those circulatory problems, again, there is commonality in the problems that actually impact the healing ability of these types of wounds. So there's lots of data that have shown that they all have some form of an increased inflammatory state. They have elevated levels of inflammatory cytokines, increased inflammatory cells present in the wounds. And they enter this phase of really chronic inflammation where there's continued tissue damage, but ongoing attempts at repair. So to start with venous leg ulcers, the underlying cause of venous leg ulcers is some form of impairment in the calf muscle pump function. And this may come from problems in the deep veins, which could be deep vein thrombosis or incompetence in the venous system, problems in the surface veins, which is primarily incompetence. It can be problems with limited ankle movement or limited calf muscle function, so that calf muscle pump doesn't work properly. And what this results in is what's called ambulatory venous hypertension. So just to show you from the pathophysiology, just imagine this is the calf. That central part is a deep vein encased by the muscle and the fascia around the muscle, and outside of that are the superficial veins. So normally when the calf contracts, it compresses those deep veins, it pushes blood back up the veins back towards the heart. But when the muscle relaxes, what happens is the valves stop the blood from going down. So the pressure in those deep veins drops down from somewhere around 110 millimeters of mercury to around 40 millimeters of mercury in normal people, with normally functioning deep veins. And as a result, the blood in the surface veins can flow into the deep veins because that's its natural path to flow through the perforating veins, and that overall assists that pressure to drop. What happens when the valves are not functioning or the calf muscle is not functioning adequately is that when the muscles contract, they can still pump the blood out. And then particularly when the muscles are not functioning normally, so when the veins are not functioning normally, blood can reflux back down into those veins. So the pressure is unable to drop. And also then the blood from the surface veins doesn't have that gradient to flow into the deep veins. So the pressure remains high in both the deep and the surface veins. And this is what's referred to as ambulatory venous hypertension. Also, you can imagine if the muscles are not working properly, then there is an inability to actually pump the blood out sufficiently and allow the pressure to drop down. And this is what happens in people with venous problems. So normally, if you look at this is venous pressure. This is measured in centimeters of water. This is over time. So when they're standing, whether you've got normal veins or whether you've got deep venous insufficiency or varicose veins, the pressure is somewhere around that 110 mark. When you walk or exercise, if you've got normal veins, the pressure drops. If you've got deep venous insufficiency, it doesn't drop as much. If your deep veins are working okay, but you've still got surface varicose veins, it drops, but not to the same extent as normal. Then when you go back to standing, it reverts to this higher pressure again. And we can measure this in different ways. That's a very invasive method to measure the pressure in the veins. The modern way of doing it is with what's called an air plethysmograph. So this actually captures the volume in the legs. And what it can measure is with movement at the ankle, it can measure what's called the ejection fraction. So the amount of blood that can get pumped out of the leg. And then it can also look at the refilling time. So how long does it take for that to refill? So it's a combination of, if the valves are not working, it refills quicker, but also you may have an inability to pump a full load out of the leg, particularly if the muscles are not working normally. So how does all of that increased pressure translate into a problem with ulcers and wounds? And this is where there is still a relative degree of uncertainty. And we do know from different studies with laser Doppler, transcutaneous oxygen, that there is hypoxia in the tissues. So that we can measure, that we can see. Exactly how that goes from ambulatory hypertension to reduced tissue oxygenation, that's where the theories come in. And I've just put down here a number of the theories that are there, and it's still not really clear which is the exact mechanism, but some thought of there being some shunting of blood through arteriovenous shunts in the capillary bed, there being a barrier to diffusion. So this is just showing you some fibrin deposits around the little capillaries, and it's thought that this impedes oxygenation diffusing into the tissues. There's a thought of white cell trapping in the dermal capillaries, which actually limits the amount of blood that flows through them. And there's also some thought that the perfusion and reperfusion injury impedes transfer across capillary beds as well. So that's really the underlying problem with venous leg ulcers. So then the question is, so how do we help to improve calf muscle pump function? And by doing that, how do we help to improve venous leg ulcers to heal? So these are the options available to us. Compression therapy, I think you all know very well, and I'll touch on that in a minute. Exercise also has been shown to significantly help the calf muscle pump function. The muscle pump activation, so using neuromuscular electrical stimulation of the common peroneal nerve by the Gecko device, which I think you all have some familiarity with. That also helps to improve the calf muscle pump function, and there's plenty of data on that now. And then ablation of incompetent superficial veins, again, another way of improving the muscle pump function. So if you stop that reflux down the superficial veins, it allows the pressure to reduce a little bit more, and therefore, helps to lower that level of pressure when patients are walking. So compression therapy, I think you're all pretty familiar with this. There are different methods of compression therapy. Obviously, the current common one is multi-layer bandaging, which has, protection layer, compression layer, retention layer. There's debates about whether elastic or inelastic are the better, but both of them can deliver good levels of compression. Then there are adjustable wraps that use a hook and fastener mechanism, which for some people is easier to use. And then stockings can be used. What we do know about all of these, whoops, I'm just going back, sorry, is that in various different studies, it's been shown that compression does improve calf muscle pump function. It does improve oxygenation in the microcirculation, so through laser Doppler and TCO2 measurements. Exercise, I'm not going to go into exercise in any great detail, but this is just an example of how a supervised exercise program can help improve the ejection fraction, which is the amount of blood that's pumped out of the leg. And it also reduces it slows down the venous refilling, which is another method or measure of how effective the calf muscle pump is. So this is just showing you before exercise in patients with venous disease and after exercise. So it improves significantly. This is in normal subjects, and this is after exercise. So there's still a difference between these, but you can see the pressures, do improve significantly. And this is before and after the exercise programs. So you can see with the exercise program, that ejection fraction improves significantly in those with chronic venous disease. And the muscle pump activating device, which you all have some familiarity with, or the gecko, again, there is a lot of data now that is able to show us that this does improve venous and arterial function in the leg. And I'll come on to the arterial function later when I'm talking about peripheral artery ulcers. But from the point of view of venous flow, it does improve in healthy subjects, but it's now been well shown in patients with venous disease that flow in the arteries and in the veins improves significantly with the use of the gecko, and as well the laser Doppler or flux on the foot, and also using the spectral contrast imaging demonstrates an improvement in the microcirculation. So we do see, significant improvement in the microcirculation, the calf muscle pump function with the use of the muscle pump activating device. And this is just showing you here the use of that, just some summary of some data. So this is with the muscle pump. So this is without the muscle pump activating device on the leg. This is with it on the leg. The wider areas or the lighter areas are where there's increased perfusion, which increases significantly just compared to the normal pulsation in the leg with the arterial flow. And this increases it both in the wound and in the peri-wound area. And then there's venous surgery. So what venous surgery attempts to do is really improve the superficial veins. There's very little we can do, and although there have been many efforts to try and improve the function of the deep veins, to date there really isn't any reliable or consistent method of improving the function in the deep veins. However, when there is incompetence in the superficial veins, then there is good data now that whether you do or whether you don't have problems in the deep veins, you can still improve the calf muscle pump function by treating those incompetent superficial veins. Clearly, you improve it more if the deep veins are functioning better, but you still improve it significantly even if the deep veins have got reflux. And we can use traditional surgery, or we can use something like this, which is EVLT or laser fiber venous ablation. So this generates some heat and basically closes down that vein. And so the reflux disappears. And there's good evidence that, once again, this improves muscle pump function, microcirculation, and improves ulcer healing. And I'm just going to touch on a little bit on the Canadian consensus statement on the management of venous leg ulcers, which I think you've all, heard of a little bit in the past. I'm not going to go into it in a lot of detail, but I just want to highlight a few elements of this. So just to reiterate what this was all about, was trying to bring some of the new information that we have into where does it fit into our practice. So this is just repeating for you that slide that I showed before this. You can see the active pulsation here, what happens with the muscle pump activating device. This is the pulsation that happens with just the normal heartbeat. So you can see that significant improvement. And then this graph here shows you from an RCT that Keith Harding and his group performed, looking at the improvement in wound healing that occurs when you add muscle pump activation to standard compression. And just to sort of add to that, there's just been a recent publication from Holly Murray that's demonstrated in a sort of a real life environment that doing the same thing, not in the constraints of an RCT, also does improve healing. So really, corroborating evidence to this RCT that Keith and his group did. But just to sort of show you, with this study, there was a run-in phase where patients were put into compression. So both groups were in compression. Then they were randomized. One group continued with standard of care compression. The other one had gecko added. And what happened then was that there was significant improvement in the rate of healing in the group that had the gecko added. So new information that really adds to what things we can do when we're treating patients with venous leg ulcers. And then the other elements that we wanted to incorporate into this consensus statement was, the basic principles of time. So how you manage wounds, particularly, addressing issues of tissue, of infection, of moisture, and how do you address when an edge is not advancing. And then also to bring in an approach to advanced wound therapies, of which there's been some recent work just showing that you can, in a sequential manner, start to add in new therapies, but you have to have done the basics first. And I'll go through in the consensus statement, how that sort of pans out. Just to show you, this was a Canadian initiative, a multidisciplinary panel, 19 panelists from across Canada, and from many different disciplines, all from different regions. So some physicians, some surgeons, family docs, rehab docs, many nurses, many NSWOCs, a therapist, some researchers. So a very broad spectrum of people. And I'm just going to highlight on a few slides some of the key elements because I think it's important to touch on those in this talk. So one of the key things is that when you treat patients with venous ulcers, as I mentioned at the outset, you have to treat the underlying cause, which is the impaired calf muscle pump function. So what's our approach to that? So the standard approach, that all of us have used for many years is to use optimal compression. And this is assuming the patient has a normal ankle brachial pressure index. And the optimal compression we strive towards is 30 to 40 millimeters of mercury. There are different ways, as I mentioned before, we can achieve that, but the goal is to get patients into good compression and also to encourage calf muscle contraction exercises. And it can be a daily walking regimen, it may be supervised regimen. The next thing is then what this consensus statement was trying to do was okay, that's the broad principle, that's the gold standard, but what if you can't achieve that? And then what do you do then? So give you some guidance in that. And so there may be many reasons why your patients can't tolerate optimal compression. It may be they've got a reduced ABPI. It may be they, for some reason, are unable to tolerate compression. So here what you look at is going to a lower level of compression using, one of the so-called light systems of compression in the multi-layer systems. And you'll do that as long as their ABPI is above 0.5. And obviously with more caution, the lower it gets. But if you come to that, then the next point is you do that, plus you add in the muscle pump activator. So you're unable to use optimal compression, but you're doing something, but you can improve it further if you use the muscle pump activator. So this is a very strong indication for using that in these patients. Similarly, if patients can't tolerate any compression and you just might use some form of stocking it, again, it's very appropriate at that point to do something to the muscle pump, and you can do that with the muscle pump activation device. And then obviously in patients who have other, problems at times, we also recommend, particularly if they can't tolerate compression, they spend some time with their legs elevated. And then the other elements within this consensus statement were, what do you do with the ulcer itself? So one is to treat the underlying cause, but you've got an open wound you've got to deal with. And this is where the principles of time come into this. So, the standard, you cleanse the wound and the surrounding skin and you use some form of, if possible, antimicrobial solution, and a good solution these days is hypochlorous acid. But then you look at the debriding the tissue. So if you've got devitalized tissue, you deal with that. If you've got any level of infection or inflammation, you deal with that appropriately. So that's the T, that's the I. And if there's a problem with moisture, that's the M out of time. You look at dressings that either wick away or take away the excess moisture or retain moisture if the wound is too dry. And then we obviously manage other things like pain, the surrounding skin, and we have principles if they're deemed to be non-healable. What's a really important thing is that you should regularly measure the wound. So at each visit, or if they're seen on a regular basis, weekly ideally, but if they're less often, then see them and measure it at each visit. So you've got a way of capturing what's happening to that wound. And then, of course, the next thing is, so what do we do if the wounds aren't healing? What's our strategy and approach? So this is what the consensus statement is trying to give people guidance on. And we look at, that sort of non-healing approach is if they either have no size reduction in 2 to 4 weeks or less than 30% at 4 weeks after initiating treatment. So these are the principles of what you should do. First thing, review the diagnosis. Make sure you've got it correct. Make sure this isn't a skin cancer or there isn't any other underlying medical problem that might be contributing to the ulcer. So recheck that diagnosis. The next thing is check that the treatment protocol that you've recommended is actually being properly implemented and adhered to. And then also check that there is no active infection or inflammation that needs to be dealt with. Once you've done those things, you're sure that you've got the right diagnosis, you're sure that the compression is being adhered to, there's no evidence of infection, then the things to do then is to really make sure you've optimized the calf muscle pump function. So, just recheck that compression system, as I said, review the exercise program. But then this is a time, if you haven't already used the muscle pump activation device, this is a time to add it if the wound is not responding. And also reconsider, the potential for superficial venous ablation, which you would have already considered before, but reconsider it at this point as well. But certainly another place and a role for when the muscle pump activator is a good adjunct either to the poor compression, but maybe the best the patient can have, but based on the study from Keith Harding and Holly Murray's groups, even with good compression, if they're not healing, then you should be adding it in at this time. And the other thing then, if you've got all of that, you've got all the compression, you've added the MPA, the diagnosis is right, there's no infection, then this is where this approach to advanced wound therapies comes in. So, and this is a sort of a sequential algorithm for looking at the things that you can do and add to the wound to try and encourage healing. So one of the first things is add a dressing that is both antimicrobial but also disrupts or eradicates biofilm. And you use that for a period, often 3 to 4 weeks. If there's no response, then go to something that's inhibiting proteases, which we know are present at elevated levels in non-healing wounds. And there are dressings that will do that. If it's still not responding, then look at how do you improve the wound bed, and that might be by using negative pressure. Negative pressure does other things as well, or adding a matrix substitute, which helps to improve that wound bed. If it's still not healing, then the next is the opportunity to add growth factors. We don't have a lot of options, but we do have some dressings that have levels of growth factors within them that can help the healing. And ultimately, if you've gone through those advanced wound therapies, then the final thing is to add new cells, which might be simple, which is more accessible, a skin graft, or cultured cells or skin substitutes, which are not quite as accessible. And then obviously there are other adjunctive therapies to consider, which don't have many of them as much evidence for venous leg ulcers. Some of them have more evidence for other types of wounds, but certainly things to consider at that time. And the final thing is ulcer recurrence, because these do tend to keep coming back. And this is where lifelong compression is important. And, with a lot of patients, they may not be able to tolerate the best or the optimal compression, but even some level of compression is appropriate. So here, still encourage exercises, educate them on the need to prevent ulcers from recurring. And again, reconsider even at this point whether superficial venous ablation may be appropriate for your patient. So for those of you who haven't seen this before, you can access this if you like. If you want to just scan that QR code there, that'll take you to a website where you can download this free. It's a completely independent website. And you can see also this has now been endorsed by a number of organisations, nurses specialising in wound, ostomy and continence care. I haven't got it on this slide, but also it's been endorsed by the Canadian Home Care Association. So certainly, this has been adopted by these national organisations within Canada, and there is a move to go beyond Canada with this overall view on how to manage venous leg ulcers. So just to sum up, really the approach to treating venous leg ulcers is to institute some therapy immediately, and as long as their ankle brachial pressures are not reduced, then that therapy is primarily directed at treating the underlying calf muscle pump problem or ambulatory venous hypertension. So compression and exercise. We assess if they've got any reflux, and maybe they might be a candidate for surgical treatment in their superficial veins. But also at this point, particularly if there are any delays accessing some of the therapy, then we consider using muscle pump activation device, but particularly if they're not able to tolerate full compression, and then also if they're not responding to optimal full compression. So, and then overlaid on top of that, which I haven't got on this slide, of course, is the management of the wound, which does incorporate the principles of wound bed preparation and the time algorithm, and then an approach to the advanced wound therapies. So now I'll go on to peripheral arterial disease or peripheral artery ulcers. Here the pathophysiology is a little bit more straightforward, if you like, because the end problem here is an impairment in the microcirculation. And here it's due to, problems in the arteries themselves. And in most cases, the vast majority of people, the problem is atherosclerosis. Some patients will have an embolus that's thrown off and it's occluded arteries, maybe an acute or maybe a chronic event. And it may also come from other aneurysms and things of that nature. Some patients may have we're jumping back there, sorry about that. Some may have, some absent ulcers because of trauma. Some can have other conditions in the smaller vessels, or it could be larger vessels as well, vasculitis. And there can be other conditions like shunting from arteriovenous malformations or arteriovenous fistulae that lead to ischemia in the limbs. But it all results in a lower perfusion in the microcirculation and has that net effect of the same mechanism that I described at the outset of leading to increased inflammatory cells, increased inflammatory cytokines, and that sort of chronic inflammation where you've got continued attempts at repair, but at the same time, there's ongoing damage to the tissues. Just showing you the type of wound that's involved. So what do we do when we have patients, with a problem with an ulcer due to arterial disease? So obviously we want to improve the local microcirculation, and there are some simple things to do to begin with. Stopping smoking is a really, really important one. A lot of patients who have some level of arterial compromise, it will be made worse by smoking because components of the inhaled smoke cause vasospasm in the small vessels. And if they stop smoking, those vessels are able to dilate a little bit more. It can improve the circulation within the tissues and can help that healing process. So still, even if they've been lifelong smokers, it's still definitely worth trying to encourage them to stop smoking. Then obviously we do look at, things like arterial reconstruction. I'll just touch on some of that shortly. Exercise is an important thing, probably a little bit more if patients have got more claudication type symptoms, but it can also help the perfusion with wounds as well, as long, of course, as though they're not causing damage, because a lot of their wounds are on the foot. So it's not always as easy to do a lot of walking. And then muscle pump activation, again, which I'll show you, also has a significant role in the management of ulcers due to arterial disease. So as I think showed a little bit in the previous talk I gave, these days a lot of our work is using percutaneous transluminal angioplasty. And I've just been in the OR today, and this is the type of OR suite I was in with a C-arm in the room. The way we do things is we put wires, usually through the femoral artery, down into the vessels. In this case, you can see there's a superficial femoral artery in the thigh. You can see a couple of areas or several areas of stenosis. So we pass a wire through there. We get a balloon into it where the atheroma is, dilate that. And you can see, if you look on this right-hand side, so that one there, as it crosses the bone, that's improved quite a bit, but these ones haven't. And there's a couple of channels there. So that's where there's a little bit of dissection of the plaque there. So in these sort of circumstances, we look at putting in stents. And this is what a stent is. It's basically a metal. They're made of different types of metal, nitinol, steel. But basically they're a self-expanding or a balloon expandable. So you put them in, you expand them, and this is showing you, improving a renal artery, which is, you can barely see a lumen there. But once you've got it in, here it is, you've got a great lumen. We use this in iliac arteries, superficial femoral arteries, tibial vessels, some of the mesenteric vessels, obviously, as well. But most of our use would be in these iliac, superficial femoral and tibial vessels. And then we can do bypass surgery in these patients to improve blood supply. So this is just showing you, patients can have occlusions at different levels. So this is in the aorta and the iliac arteries. There may be occlusion, maybe stenosis. So we have a few options. So one option in treating this is to dilate that stenosis, as in here, and then do what's called a femorofemoral bypass, to take blood from the right leg to the left. The traditional way we've often dealt with these is to do an aortobifemoral bypass. So join a graft on up here and go down to the femoral arteries in each leg. And then sometimes if a patient's not fit enough for that procedure, we can do what's called an extra anatomical or axillobifemoral bypass, where we join a graft onto the axillary artery just under the clavicle on the chest, tunnel that down under the skin, join it onto the femoral, and cross over to the other femoral. And we do lots of bypasses below the knee. So they're often called infrainguinal bypasses, which means below the inguinal ligament. So the inguinal ligament runs from the anterior superior iliac spine to the pubic tubercle. So this is an example of a femorotibial bypass. So we're putting the graft, in this case a vein graft, onto the common femoral and taking it, excuse me, taking it down onto, this is the perineal artery, but we can put it onto the popliteal, above the knee, below the knee, anterior tibial, posterior tibial, perineal. And this is just an example of that sort of an operation where we've used the patient's veins. These days we use smaller skip incisions, so we try and retain some skin bridges to allow better healing of the wounds. And then we can do other things like a femoral endarterectomy, which is reserved more for where there are very focal, often very calcified coralline plaques, and the femoral artery is a common area for that. So you can see the arteries above and the arteries below look pretty good, but the problems are pretty much just there. So here we open the artery, shell out that plaque, and then close it by putting a little patch of material on just to keep it widely open. That's an endarterectomy. The other place we do that is in the carotid arteries. And then, of course, there is the muscle pump activating device. And just to sort of go through the evidence for that, we do know, as I said before, so in healthy subjects, there's good evidence of what it does to the arteries, but also what it does to the microcirculation. But now there's good evidence as well in patients with arterial disease that it does improve blood flow in both the femoral artery and the tibial arteries. It also does, as I mentioned before, improve the venous flow. But in addition, in patients with arterial disease, there's once again good evidence that it improves laser Doppler flux on the foot, and with laser speckle contrast imaging, we see the same thing as well. So there are studies, and I'm just going to sort of show you that same slide again, but the same is true for arterial ulcers as is for venous ulcers. And indeed, there's a further study on diabetic foot ulcers that shows that if you use the muscle pump activation device, you get an improvement in the microcirculation, both in the wound bed, but in the tissues around the wound bed. So if you think about, we have a patient with an ulcer due to arterial disease. So what's our sort of immediate approach to these? Well, the first thing, if they're smoking, has got to be to try and stop them from smoking, because that's a big thing to help the wound itself. But also, if they're going to have any arterial reconstruction, it's really important to try and get a longer success, if you like, out of any procedure, be it an angioplasty or a bypass, because if they keep on smoking, there's much more risk of those procedures failing and failing earlier. So we get them to stop smoking. We assess their arterial status, and we think it's and we sort of talked about the diagnosis before, but not in this talk. But we think about, clinically it looks like an arterial wound. Then we want to get an ultrasound, which is the easiest way of getting at least some sense of what the arteries are. Then if we're going to do intervention, we'll generally do a CT angiogram. But the other thing we can do early on, while these patients are waiting for all these things, if we think they've got an arterial ulcer, is to say, well, how about we get them a muscle pump activation device on their leg, because we know that improves the microcirculation. And yes, ultimately, we may want to do something to their arteries if we can. But this may be a good temporizing measure while we try and get to that point. It also has another role, which I'll come on again. Once we've done that assessment, if there's vascular reconstruction that can be done, then we would plan to do that. But again, if vascular reconstruction is not possible, just simply because the disease is often more distal in the smaller vessels, or in patients who've had vascular reconstruction, things have failed, and they've really got to the end of what you can do in vascular reconstruction, then we think about, and here is a very, very good time to look at using the muscle pump activation device, as well as the time when patients are having delays in accessing care. But here, what it potentially has the possibility of doing is helping to prevent going on to an amputation. And I haven't gone into the details of any of the amputations today. But again, this is one of the good indications, which it's only just starting to become, if you like, more common knowledge for clinicians to be thinking of using muscle pump activation device in these patients. And even with vascular surgeons, they're only just starting to become aware of the fact that this is a very good tool to use in these circumstances. So, Troy, at this point, I will pause there and happy to take some questions.
Amazing. Well, thank you so much for taking the time to go over this. And I think it was great. We've got some awesome questions that have been coming in so far here. And I know that Jeff Forney, who is with Perfuse MedTech, has been answering some related specifically to gecko in the background. So maybe we'll start with this one first here. This is going back to the beginning more, talking more about compression stocks. And someone was just wondering whether there are any specific conditions that you'd be aware of in which compression stockings should be avoided, even when the skin condition is intact and healthy.
Yeah, so I mean, the main time to avoid using them, or at least to even use lighter ones if you have to, is in people who've got any level of arterial problems. So if their ankle brachial pressure indices are low, so below 0.9, then what you would look at there is going to a lower level of compression, just like you do with the bandages. You would look at the same with the stocking. And certainly, if they're down below 0.65, you may consider not using any form of stocking, just going to some form of stockingette. And that's when, when you're treating patients with venous leg ulcers, if they've got an active ulcer, then that's when your muscle pump activation device, it really is a very, very helpful tool to have because they can't use compression, which has been our gold standard for improving calf muscle pump function. But now we know we can do it, um, actually improve it, even more, but we can do it even if you can't tolerate compression.
Yeah, well, thank you for touching on that. And I know we had a couple questions earlier, and you had shown the QR code for the consensus statement there. I did put the consensus statement link in the chat here too, in case anyone needs it. I'll paste it again, just so you have it handy there. But thanks for sharing that again as well. Next question we had here was, what is the best approach to prevent the recurrence of venous stasis dermatitis, especially when it leads to severely compromised skin, with large amounts of serosanguinous exudate affecting the entire lower leg? So it's more
Yeah.
specific situation here, but yeah.
Yeah, no, good question. So the stasis, it's often called stasis dermatitis, a few different names for it, but it is basically on that whole spectrum of chronic venous disease. So, and it's that change that ultimately leads to the development of ulcers. So, the things that are important for treating venous leg ulcers, so compression is really important for supporting the stasis dermatitis. Now, so there, if there are not open wounds, you may use stockings. If the wounds are open, then you may use bandages or wraps. If there is, some inflammation in the skin, then, with the support of your dermatologist, you may add in some form of steroid cream in combination with the compression. So just a topical steroid element. And then in people who can't tolerate compression, once again, you have that ability to improve calf muscle pump function by two other things, one being exercise if they can exercise, and then the other is the muscle pump activation device. So what you're trying to do is you're trying to improve the calf muscle pump function by the different things you can do. And then, of course, the other one, which I haven't touched on, is if they do have incompetent superficial veins, then having those treated actually can help. And there's an increasing body of evidence that even with people with ulcers, like 30 years ago, it wasn't thought that treating superficial veins was really helpful in patients with ulcers, but there's been a lot more research since, and it's demonstrated that treating the superficial veins, if they're incompetent in patients with ulcers, does help healing. So you've got all of those things, as part of your armamentarium. So I hope that answers the question in some way.
Yeah, and I know you've kind of covered this a lot too when we were talking about the compression and what your answer was right here too. So I was just wanting to clarify again, is there a concern that if there is PAD and you're doing these exercises, is there concern about the legs getting swollen, and does that play a role with compression? I think that's what you're trying to get at. Marcia here is asking the question.
Yeah. So mostly if people are exercising, their legs actually don't swell so much. It's more if they're sitting immobile that they tend to swell. But if you are getting a level of swelling, compression helps if they can tolerate it. But if they can't tolerate it, then compression alone, well, you may only be able to use stocking it. But that's where, again, something like the muscle pump activation device can be very helpful because it works whether you're walking or not walking. So, when you've got it on, it's every second it's giving a muscle contraction, which is helping to improve calf muscle pump function. And so, it's another way, and particularly if you've got people that can't tolerate compression because of their artery disease, they're getting swelling, they can't exercise, then a good indication there is to use the muscle pump activation device in those patients, which does also, because of its activity, help to reduce edema as well.
Fair enough. And I guess let's pivot then to specifically ask some questions about the muscle pump here and the Gecko device. Some people are asking a few different questions. One that just came up here is whether you can put Gecko on both legs.
Yes, no, you can do that. There's no problem with doing that. It's the same device with slightly different parameters is used by a lot of athletes, particularly in some of the elite sports for recovery after some of their sporting events or their games. And they put it on both legs, for a period of time. And absolutely no problem with that. But no, you can put it on patients with both legs. There's no problem with that.
And you don't see any, oh, sorry, Jeff, I don't know if you
So
want to
yeah,
hop
I
in
just
there
want to
for.
add to that, Troy. The reason that we apply it to one leg is economics. When you apply it to both legs, you get systemic blood flow. When you're looking to get blood flow into the heart, to the brain, to both legs, whatever. But there's really diminishing returns in terms of wound care. So it's applied to one leg for economics.
And thank you for expanding on that too here. And I might bring you in for a couple questions when you talk about more about how we get the gecko after, but maybe we'll get through a couple more of these here too. One question here from Jazz was asking, I just had it here. Here we go. Is there a risk of dislodging an occlusion when using the muscle pump activator?
So the short answer is no. I mean, most arterial disease, so chronic arterial disease, it's due to atherosclerosis, which is very firmly embedded in the artery. I wonder if you're thinking about maybe DVT perhaps, and which a fresh DVT, there's always a little risk when people do anything very much of dislodging it, but within a few days, the DVT is pretty much adherent to the vein. So you have not a great deal of risk of dislodging that. With something like the muscle pump activation device, its primary activities on the anterior and lateral compartments. It does stretch the posterior compartment. Most of the DVTs occur in the posterior compartment and up in the popliteal or femoral vein, which are not directly affected. So there's a tiny risk, I guess, is the short answer to that, but it's a very small risk. Would be no more than the patient walking to the bathroom, for example.
If I can just add to that, Dr. Stacey, the device only generates 60% of blood flow of continuous walking. I shouldn't say only, because that's actually pretty significant. But the point being is that if you're comfortable having your patient walk, this is no more blood flow than they would get from walking.
Yeah.
Yeah,
good point.
I think that's a great way to contextualize it there. One question that Sherry had here was, is gecko being used after arterial revascularization surgery? And if yes, how quickly after surgery should it be initiated?
That's a really great question. There have been some initiatives to try and do some studies looking at it. I mean, after arterial revascularization surgery. So probably the short answer is we don't really know those parameters at this time, but definitely it's something that we're actively looking to study. It has been used after some other procedures like orthopedic surgery, also after renal transplants. And there it's put on pretty much straight away. If you think about arterial revascularization, there's no reason for it not to be started straight away unless there's some problem with the wounds, but you rarely have wounds out where you put this on. They're mostly on the medial side of the leg. So, Jeff, did you want to comment on that?
No, I just think so I was answering another question at the same time here, but I don't think. So can you repeat the question?
Yeah, just the timing of starting it after, say, arterial surgery. I mean, I don't think there's any reason to delay it unless there's.
No, I think, in fact, if anything, by starting it immediately, you've got DVT prophylaxis, you've got edema management, you've got wound healing. The renal transplant study in London, Ontario, showed a 2/3 reduction in surgical site infections, and that alone is possibly an outcome we could expect in after arterial procedures.
Totally. Yeah.
And I think we got a great question that just came up here too. Have you ever seen this used as a preventative measure? What kind of patients in primary care setting would benefit from the gecko?
Yeah, so I mean, some of you may be familiar. I think one of the original, well, and still is one of the potential uses of the gecko is in preventing deep vein thromboses. And it has a particularly unique role in patients who can't tolerate anticoagulants and who may not be able to tolerate other forms of mechanical compression on the leg or mechanical pumps and things. So it's definitely being used. There are quite a number of stroke units, particularly in the UK, that use it. It has good indications in patients who, have need some DVT prophylaxis following trauma, or other things like subarachnoid hemorrhages where you don't want to give them any form of anticoagulation. So, and I think you're asking in the primary care setting. You might consider it for patients, for example, if they have things like heart failure or significant edema, they maybe have to be bedridden because of their other comorbidities. You might consider it, to help reduce edema in those sort of situations. But Jeff, you may want to comment further.
Yeah, one of the other areas, and this actually comes from a suggestion in British Columbia, it's the patient in Victoria in the summer that really does not want to wear compression.
Yeah.
And so the idea of the ulcer recurring in September, if you put the device on during the summer, that might actually be a pretty cost-effective way of preventing dealing with the problem in the fall.
Be very useful for all my former patients in Australia in the summer down there too, Jeff.
And then I guess just to clarify this too, because I think we've kind of covered it a little bit, but could you use the gecko while a patient is mobilized, or it would be in place of the movement?
So you can have it on. I mean, certainly there's no problem in having it on when you're walking around. The advantage of it, of course, is that I mean, obviously when you're walking, you're getting the muscle pump activation. When you sit or lay down or whatever, or stand, you're not getting it. If you've got the gecko on, you continue to get some benefit, when you're resting. So it's got a sort of an additional benefit, and that's probably, I mean, if you think about the studies that have shown the improvement in healing of venous leg ulcers above what compression can do, if you add the gecko in, it's probably because, so those patients have got good compression, that many of them are on exercise programs. But what happens when they sit and rest is they're not getting that benefit. And the compression works primarily also when you're exercising. So if you've got that continued improvement when you're not exercising, that's probably why you get this increment in healing. So I think if you think of it like that, it adds something that even is continuous when you're not getting that continuous improvement that comes with the walking exercise program.
And if I could add to that, mobilizing is kind of like how long is a piece of string. If a patient's mobilizing and super active, that's one thing. But if they're mobilizing and walking, 400 or 500 feet a day, that's different. The gecko device generates 60% of the blood flow of continuous walking. Wearing that for 12 hours a day, that's like a 6-hour walk, right? So it's hard to compare the mobilization to that in terms of blood flow.
And what we'll do now, because I know we're getting towards the hour, I know we had quite a few questions, mostly for you, Jeff, here, talking about how we can order this, who can order it, does it need a doctor's order or a physician's order? Did you want to maybe just touch on a little bit about how people can get gecko, or how they can learn more maybe about ordering it in their province?
Yeah, well, certainly it's available on the formulary in a couple of provinces. We're working on getting it into the Ontario formulary. You can get it through ODSP, special access. It's widely available in long-term care. Medline carries the product. There'll be other companies that soon will be carrying it as well. If you have any questions, if you write to me at info@perfusemedtech.com, we'll certainly help you to access the product.
Absolutely. And you can always, we're going to be sending, as we said, a certificate of attendance to everyone here as well as the recording. And if you even just wanted to reply to that email, we can get you forwarded on to Perfuse MedTech to get you in touch there. And maybe what I'll do too, because we're going to be having 2 more editions of this 6-part series. They're going to be happening in June. But in between that break, Dr. Stacey and Dr. Gary Sibbald will be presenting at our national conference as well. And I think Dr. Stacey had might be looking at some posters potentially, or might have some posters at conference as well. So if anyone is interested in this subject and want to learn more, you will definitely have the opportunity to come to those webinars in June. Again, it's going to be on our nswac.ca/webinar-series page. But if you are interested in coming to talk to Perfuse MedTech at our conference and learning more about microcirculation and about a lot of this wound care topic we've been discussing, you'll have a chance to do so as well. That our conference is going to be happening this May 21st to 25th. In Montreal. It'll be in person only for that one. So thank you for letting me give a chance to shout out our conference there, Jeff and Dr. Stacey, but we know that we'll see you there as well. So hopefully you're okay with that too. What I'll say now is I guess we'll say thank you so much, Dr. Stacey, for your education today and your expertise as always. We really appreciate you taking the time to come out and do this. And I know it won't be the last time we'll see you on a webinar here. So we appreciate everything you've been able to give to us. And we hope everyone on the line has had a great time today. And we look forward to hopefully seeing you at another webinar or in person in Montreal this year. Thanks so much, everyone.
Thanks, everyone.
Thanks, Troy. Thanks, everyone.
Have a good night.